Welcome to the Benefits Boost,
where we bring game-changing ideas to you,
the people shaping the future of benefits.
Let's jump in.
Here we are. Rob, I've heard so much about you. It's like kind of surreal to finally meet you because I literally hear from almost every member of my team about you. So it's like a real honor and a pleasure.
I hope it's good stuff.
I can't believe you guys hadn't met. I guess it surprises me.
Rob, just for the audience here, do you mind just kind of telling us a little bit about yourself?
Yes, be happy to. I'm Rob Huffaker. I'm a broker in Chattanooga, Tennessee. I am in my 43rd year of being a broker. It's a great business, lots of challenges. I started in a family property and casualty agency and opened the life and benefits department in 1982. From there, I think you said, how did I get in the brokerage business? I said, hey, Dad, I want to come to work for you. What should I do? And he said, go into the life business. And so I spent a little time, and I don't know how far you want me to go into this. You asked a question about how I got in the brokerage industry. Do you want me to answer that here?
Leave it to me to ask the questions. No skipping ahead, Rob.
I will. Okay, I'll let you do the asking. So I'm a broker with MMA, who's wholly owned by Marsh McLennan Agencies out of Chattanooga, Tennessee.
This podcast is sponsored by, Airbo. We make benefits education simple and engaging and free. We really believe that everyone should have access to wonderful benefits education so that your employees have all the resources they need to thrive using your programs. And let's be honest, so that you don't get all that employee noise. You can sign up for our free AI tool, free microsite, and lots of other great stuff at airbo.com/free.
I guess to start off with a somewhat softball, I've always felt like hearing from team members like Kay about what you're working on, that you have a very unique perspective on where the industry should be going, and you're really putting pen to paper and really making it happen. What is, do you think, unique about your industry perspective that feels fundamentally different than everybody else that you generally speak with?
That's a hard question because I don't know what other people are thinking and doing other than what I have seen. About the industry, I think health insurance is broken. I like to say I'm in my 35th consecutive year of predicting only 5 more years of health care. Never ceases to amaze me how expensive health insurance has gotten, and the fact that employers are still paying 50 to 75 to 80% of it. It just amazes me. Recently, what's happened is employers, as they've tried to absorb that cost, provide benefits to their employees, they've done a couple of things. One is they've raised the cost to the employee through the payroll deductions. And second is they've cut the benefits. And the benefits being cut and the price going up, our participation is falling. Earlier in my career, it was normal to have 85% participation inside of a group health plan. Today, 70%. Many groups much, much lower than that. And why is that? It's too expensive to buy for the employee to buy it. And really, if they need it, they've paid a lot for it and they end up bankrupt because the out-of-pocket is more than they can afford to pay. So an hourly worker with a $6,000 out-of-pocket, and they're paying, let's just say they're single and paying $150 a month for it, all of a sudden they have a major expense and they owe $6,000. They don't have $6,000. They're bankrupt. They're working out tight plans. And so it's broken. We have found ways to fix it. How that has happened is the insurance companies 10, 15 years ago, the medical insurance carriers, the Bucas, Blues, United, Cigna, and Aetna, those companies over the last 15 or 20 years have pulled all the coverage components inside and underneath their own umbrella. And a lot of those things are not working well. Nobody seems to care about it. And so we have started disintegrating healthcare, as in pulling component parts of that system back out of United Healthcare and to companies and providers that focus specifically on those areas and work day and night to improve those areas and make them work well. So what we get are significant increases in utilization and better outcomes, and those better outcomes produce lower costs, So what we're able to do is hold down cost and improve benefits so that the average working American can now afford to have health insurance and don't find themselves in that terrible spot of sitting around the kitchen table and going, what are we going to do? Johnny's sick and we don't have any insurance. We're confident, and actually we're confident because we've seen it in our groups. We've been able to do it.
I was just Googling this real quick. The leading cause of bankruptcy in the United States is medical debt, according to multiple sources like National Institutes of Health, American Bankruptcy Institute.
I believe it was Kaiser Family Foundation that did a report a few years ago that a significant number of those people bankrupting on financial debt have health insurance. Thank you very much, says the bankrupt employee to their employer. It's a real problem. When I say it's broken, there's no one believing that it's going to get better. The costs are just going to continue to climb with the industry that rewards innovation. And whenever there's an innovation, say a new drug, the other drugs in that class all raise their price. And nobody seems to be stopping it. It's a free enterprise system that is set up to break. Why? Everybody gets everything. It doesn't matter what the cost is. It's got to be paid. And everybody's trying to figure out a new way to do it.
Rob, was this something that you saw like slowly happen over time? Because you've been in the industry for so long. Like, when did you start seeing this shift take place?
I don't have it with me, but I've got the picture of Bill Clinton holding up the one-payer card back when he first became president because the costs were out of hand when he was back there. What's happened is that it's gone from, 5 to 7% of the cost of an employee from an hourly basis to almost 20%. I deal with employers who deal with these costs. Their number one demanded benefit is health insurance. American ingenuity, the productivity gains that have been received over all of these years, a lot of that has been invested in paying for this health insurance. And so it's not really a problem until the client says it's a problem. But the employees are saying it's a problem because their wages have not kept up with the cost of increases on their health insurance. So now health insurance is eating a bigger and bigger component part of their health care. So how long? It's been forever, but the new, really expensive drugs are accelerating the pace of the opportunity for this not to work. To your question, what's different is kind of through the history, what have been the potential fixes to cost? First, it was networks. The networks, we're going to get discounts from doctors and networks are going to be better. Next came in the HMO sort of thing where we would provide all the care and we would do it at less expensive of an amount. Next came consumer-driven healthcare, high-deductible health plans. Then came wellness. And then after wellness and consumer-driven healthcare, there was about a 10-year period that there was no new song to sing, no new dance to dance to. So there became a dry spot. In COVID, around the time of COVID, back in 2020, innovative healthcare eats up so much of the economy. Innovative people have started going, I need to see if I can fix things inside of healthcare. And so we found 3 or 4 areas that reduce cost and improve benefits and have been working to implement those things in our clients' groups since then. And so I've got 3 years of data on my clients that are doing that, and it is working. And how do we know it's working? It's working because our group of 10 clients, insurance brokers basically take care of a client group, and I've got 20, and 10 of mine are compliant with these ideas, are moving toward these ideas, and they're in different levels of that. But those 10 clients are 24% below a demographic and geographic adjusted norm from a cost standpoint, when the rest of the world is 8% above norm. So there's a 32% decrement between our compliant group and the rest of the world. We've seen that, and that's happened really over the last 3 years or so. We're confident that it works, and now our job is to go find clients who want to improve benefits and reduce costs, not just reduce costs. It needs to be both because there's complication in doing this that requires a good bit of struggle on the employer side in communication and understanding, and that's where you guys came in. How do we get employees to understand a disintegrated medical offering? They have enough trouble understanding the traditional medical offering. How do they understand a disintegrated model? That's what we're using you guys to help us with, is to get that word directly into the hands and minds of employees. I guess my first realization, and this was about 8 or 10 years ago, in my self-insured clients, I got an inkling that the insurance companies were making money on the drugs, as in they were charging my clients $10, paying $8, and keeping $2. And I'm kind of like, well, hold it. That's a foul, isn't it? Aren't you the administrator? Aren't I supposed to pay it? My client and I supposed to pay what you pay? I had to go through so many levels to finally get, oh yeah, that's what we do. The PBM keeps some of this money. That started me down the path of, oh my gosh, these people who I thought we were in this fight together, I find out, no, we're not fighting the same battle. They're fighting a different battle than we are. It's legal, but it's not right. So number one is you've got to carve the pharmacy away from the medical provider.
Yeah, effectively, you were supposed to be just charged an administration fee from the PBM. And in fact, there was a hidden fee that you were not being told. That was that $2 delta that was causing additional costs that you seek now to remove from the system.
Yes, it was undisclosed, unrevealed earnings. They weren't disclosing, they weren't revealing, and just found it surprising. I went to say, okay, well, I need to find something better. Met a man out of Atlanta that explained what he was doing. I said, you got to be kidding me. I don't believe you. He said, no, that's what we do, and I'll show it to you. And he showed it to me. And so I put my first client with him, and the net drug cost dropped 50% in 12 months.
Wow.
That all of a sudden made me go, wow. There are components of that require there's some administrative issues that are hard for employees to understand. The owners of the company needed to understand you're buying your drugs from Canada. You're using manufacturer's assistance. You're avoiding the big box drugstores. But the outcome of that is a 50% reduction in their drug spend with an improvement in benefit. The drugs that come from Canada go to the employees for free. The drugs that are secured through manufacturer's assistance go to the employees for free. So it's an enhancement in benefits and a reduction in cost, and it's a gigantic savings.
And was the biggest, I don't want to say hurdle, but was the biggest thing with that educating employees on how to use that new, like the pharmacy carve out?
Yes, they had to deal with someone else other than their Blue Cross BUCA plan. They had to deal with someone else with drugs, and they had to apply for the manufacturer's assistance. They had to complete paperwork to buy their drugs from Canada. Well, I've never had to do that before. Why do I have to do that now? We're trying to find these drugs at the best possible source for you and your employer. And if you get this, you get it for free. If you don't, you go back under the plan, you pay your copay, and you go through that normal process. So communicating and educating employees on that was a big hurdle first. And as we finished our first one or two of those, we went, wow, after it's over, it's no big deal. And that's a pretty easy process to run. Kate, we're not using your product to communicate that, because it's a do this or nothing, and everybody figures out it's always a hassle to buy expensive drugs anyway under any PBM. And so it's just a different direction that you have to go through to make this work. And so the population's pretty much handled all of that and absorbed it. That's a pretty easy piece. It's the next two big parts that are more difficult.
Yeah, I was going to say, I don't recall us doing a ton on pharmacy because that was pretty implemented already, at least with the ones that are already on it.
Right. And if you don't, as an individual, if you don't implement it, you don't get your drugs. They figure it out. And they only need to do it once a year, and it's something similar to what they've already been doing. And so it's not really a new piece.
Yeah. So what was the next piece you found? Was it like a similar scenario with the pharmacy?
How do you know? I'm going to ask you a question. How did you know if your doctor's any good or not?
Truly don't. I have a very amazing doctor, but yeah, if I were to take myself out of the situation with Mike, I would have no idea. You're blindly trusting
And like
somebody.
in theory, there's like health grades and all these other things, but in practice, it kind of seems like it's not real. I don't know.
No, it's very blind trust.
Well, and how most people know who's a good doctor is another doctor tells them they're a good doctor. Their grandmom tells them she had a good experience with them. They're a friend of yours. There is no tracking, or there wasn't any. And lots of people have tried to do this. And we found a vendor, well, before I go there, the difference between the top 25% best doctors and the other 75% of doctors is significant. The single best indicator of a positive outcome inside a medical condition, not the drugs you take, it's not the labs you go to, it's not the hospitals you go to, it is the doctor you work with. The doctor you work with is the single best indicator of your outcome. Why? Because technically nothing happens in the medical field that is not prescribed by a doctor or performed by a doctor. There are some functions that are not performed by a doctor. Some of those are overseen by a doctor through a physician's assistant. If you could gather information on doctor performance that is reliable, broadly based, as in a variety of carriers, assimilate that data, compare it by diagnosis against how that particular college of medicine says this is what you should do, and then track for errors, redos, misdiagnoses, extended stays, and look at outcomes. If you had that data by doctor, by condition, and compared it to other doctors with the same data on the same condition, you can determine who the best doctors are. And so we found Garner Health that is doing that. Nick Reber and his group had just started. This was 3 years ago. We wrote, don't know exactly, but maybe their 21st group with them. The difference between working with the top 25% of providers versus the other 75 is a 27% cost difference.
Wow.
27% of a big number is a whole lot of money. How currently Garner is working that process is that if you will go to a Garner doctor, depending on how you set it up, it pays your deductible. It pays your copay. If you don't go to a Garner doctor, it doesn't pay your deductible. It doesn't pay your copay. So what do? What does that give me? Better benefit, lower cost. Why? Better outcomes. Health insurance is different. Medical treatment is different than almost any other piece in our economy. The better you are at it, the cheaper it is. Why? You get well and you go home. No more treatment. The better your treatment is, the cheaper that treatment will be. Why? You're well, you go home. If you are misdiagnosed or mistreated, what happens? You stay sick or you get worse, and it costs more. That was the second revelation of, here's something to help that family, single mom with a couple of kids at home sitting around the table going, I can't afford to get care for my kids. If you'll go to the best doctor and follow their instructions, you basically have no deductible. It's 100% coverage on a reimbursement basis. And so the employers are like, I get it. And so we're able to show them the decrements and how we can steer more people in there. And so what the employers that understand this want is they want 100% of their care with these better doctors and are willing to say it's free if you use these better doctors.
Do you have employers that aren't saying yes to adding some of these on? It
Yes.
seems like a no-brainer.
Yes. The health insurance purchase is a complicated buy. The bigger the group, the more people involved in it. Generally, the front runners of large groups are benefit managers. Second line would be HR VPs. Third line will be CFOs. And very seldom in larger group does the executive group, other than the CFO or the VP of HR, ever get in there. Chief executive almost never makes this decision. And so what ends up happening is how bad is our problem? How much trouble do we want to go through to fix it? What we've found is that in both of these instances, I'm not picking on HR. HR is doing their job right. How much disruption am I going to create in my workforce to make this happen? So if they're not faced with a rate increase or a benefit cut or something else that will disrupt them, they're happy to keep on rolling. Our groups that have not done these things or started down this path have basically found themselves in positions to where, for a variety of reasons, either their employer will pay whatever. They go, yeah, health insurance costs have been increasing 5, 6, 7% a year. So a 7% increase is no big deal. And HR goes, we're done. Next, and they don't want to mix this up. It is people that want to reduce cost and improve benefits, and are willing to go through the trouble of educating employees about this is a better way to do it. Kate, you picked up right there of why in the world wouldn't people want to go to a better doctor and have it paid for at 100%? I agree with you. But the problem is that you start talking to this about to employees, their eyes roll back in their head. I got to do what? Well, I thought my network was with Cigna. What's this other thing? Cigna says my benefit's still the same, and you're saying this thing over here is saying they're going to pay they just go, I don't want to do this. People want copays. They want their doctors to tell them what to do. They don't want to mess with any of this stuff. And so it's very difficult. And so that's why we're in our 6th hour of reviewing the boilerplate presentations we're going to use with our clients to try to educate them. 6th hour of drafting and rewriting these things.
Rob, I think what you just hit on is why I'm really excited about AI in like the benefit space, because it's like got this potential to take away the need to educate people where they actually have to retain it. And they simply just need to know to like ask the question, and then they can be routed into the right place. Because I think before it's just really hard to pull that off because there's just too many things for people to know to do. What do you think about it?
Well, there are two views. One would be me as a service provider to my clients. Second would be my clients' need for information. In that group, there's two. One, you got employees, and two, you got HR and benefit professionals. The HR benefit professionals and us, AI is an incredible assistant. If you feed all of the plan designs and all of the HR regulations and all the network information into an AI system, it can answer questions in a split second, as long as it's not hallucinating and it's not misunderstood your question. All is good. I personally, from an information assistant, a research assistant, a document editor, a clerical suggester of change these things, I think AI is incredible. It makes me more efficient. It makes me smarter. It makes me less likely to make mistakes. And I think at that stage, it's incredible. But if you feed into, you guys just bought what I just sold you on cost control. Lucky me. You asked for this conversation, so you're buying what I'm selling. But if you ask AI how to control health costs, you don't get that answer. So AI doesn't know everything. If you ask AI about your industry, how do you best communicate to employees? It's not going to give, if you think you've got the best way in the world to communicate, AI is not going to give you that answer. I think you could sit there and ask it questions all day, and it will not come to your level of understanding of what needs to be done to communicate. Why? It's reading books that are 10 years old. It's looking at enormous piles of information. And so we as experts, advisors, consultants need to take the technical data, take the information that it feeds, and then blend it into something that fits that situation and works. And that's often based on experience and understanding both. And so data input, I think AI is excellent for. And quick and speedy data input to someone that then figures out how to use that. Now, repetitive task functions, it's going to be asked the same question every day, and you can program in the answer and it can understand nuance. Yes, customer service is not the second part of the HR people's questions, employees asking them questions. At some point, there will be an AI bot that will be able to answer 95% of those questions and will relieve HR of that. And I know you guys are building that process, product, and potentially it will learn enough that it can make, what I don't feel good, what should I do? Well, that'd be a great bot. Well, contact your text care provider and explain your condition. Listen to what they say and do what they say. Well, they said I need to go to another doctor. Who should I go see? Okay, well, then at that point, it opens the Garner app, finds the correct doctor, and goes, do you want me to reach out to their office and see if I can get you an appointment? I believe all of that is doable. when you narrow, these are the component parts that will work. Now apply these component parts to specific situations because your variables are smaller. When you've got an unlimited number of variables, how do you scale it down? When you scale it down, AI, I believe, in our lifetime will be able to handle that.
You hit the nail on the head. The key to doing it now is to scale down the scope of these LLMs to be very specific to benefits. I remember this like a fork in the road we had when we were doing our initial prompt engineering on it. And it was like, let's say, to use your example, it was like, hey, I'm not feeling well. Well, there was like one version of what we were building that would then turn into an emergency room doctor and triage you, which we're actually uniquely positioned to do because our chief medical officer happens to be like one of the best ER doctors in the country. And there's another version of it which could have essentially done what you'd suggested, which was like, hey, here's a service that you can use for your next step from your benefits package. And I remember we were really mulling over this because technically we could provide the emergency doctor, and actually in quite a lot of cases, a more automated version of that would produce a better output than some of the alternatives. We ultimately decided to not do that because we were like, well, look, like the entry point for this from an employee perspective is I am speaking to an extension of my benefits department. I'm going to disclose things that are inappropriate. It gets into some really weird stuff. So we started putting these tighter borders around it, and then we realized that like, oh, this needs to be like a router that essentially just gets people to the right services. And we can't have Airbo AI cannot go and like ping Garner and get the answer from them. It would need an API to do that, or like an agent that could go and, you know, maneuver their website, which is it's getting there, but like that's not really a good idea yet. But what it does do is then say like, here's a link to go to Garner. This should be your next step. And I think even that is already pretty revolutionary in my book in terms of outcomes that you get from people's literacy, because now you don't need to know that Garner even exists before you start down this journey, which reduces the cognitive load and the amount of education that's required to like proactively program people to like know this information and know navigation. Like, I think that's kind of a losing battle at the end of the day. We kind of have to just guide people when they need it because the motivation to learn is actually very low outside of those moments. Curious what you think about all that.
I think that in medical needs, general information needs, like what is my deductible? What is my disability benefit? Those things that I could look up and read or have something else look up and read for me are incredibly valuable. I've had a headache for 3 days and it won't go away. What should I do? That requires a whole bunch of questions before somebody can accurately answer that. AI is not for that. So I think that AI that is assisting plan members on what their benefits are, because that's black and white, that's by contract. You can dot the place where it shows it in the policy if they want to. I think that is incredibly helpful. The more complicated is if this, then that. And you got to get all the if this is down before you can get the then that. And I think that's where an expert or a professional needs to come in. And so I think what it's going to do is that it's going to make experts and professionals, AI is going to make expert and professionals more capable they don't have to rely completely on their memory. They have to see the response and go, yes, that's right. But what about this? And then you start that dialogue, and that's where I think it shines. I think you should continue to pursue the employer lookup is unbelievable. We have not been using that on our side, which we probably should. Kate, I don't know how close you are toward getting any of our people to where we can start servicing our groups by when they call and ask us a question, we query your AI on their policies and get the answer. But that's what we need to start doing. McGriff MMA is building their own internal AI, and they're going to load all the policies of all the clients inside of that, and then we're going to be able to query that. I don't know if I've not seen how that works yet, but that is a go gather this information for me and tell me what source you got it from and give it back to me in 2 seconds. And boom, it's done.
Yeah, and I think we have all of yours set up actually. I'll follow up on that. Yeah.
Yeah, well then we probably need to be trained because I'm not sure anybody's used. Can you tell if anybody's using it?
Yeah, I'll take a look. I'll follow up on this after.
What was the third thing that you guys identified?
Way to go, Vlad. You were paying attention. I'm glad you asked because I was going to throw it in there if you didn't, because they're the smallest dollar but broadest impact, and that is personal virtual primary care. And personal meaning I talk to the same person that has my records that I think cares for me through text with no logins. You guys, your utilization of your service went way up when people didn't have to log in.
Yeah.
Yep.
The same is true with telehealth. If people have to log in, and telehealth, the other issue they've got is that it's a national pool of providers, and depending on when you call will depend on who you get. And the bedside manner of, those are part-time employees generally, not full-time employees. It's the glue. It's the first line of interaction with the system is that if you don't feel well, text your provider and say, I don't feel well. And this particular provider called TextCare will get back to you in 5 minutes or less with, what's up? Tell me what's up. And then you start that dialogue. And if that dialogue is, I tripped in my front yard and my ankle is really hurting, they'll start asking you questions that potentially will lead to, you may have broken your ankle. Are you able to get yourself to the diagnostic center, not the one in the hospital, but the freestanding diagnostic center? I'll order that they get an x-ray on your ankle. And you go get your x-ray on the ankle. The x-ray center calls back the TextCare people, reads them the results. They call you almost when you get back in your car and tell you your ankle's not broken. Let's get you a brace. What pharmacy do you use or medical provider? What part of town do you live in? I'm going to order you a brace. You pick the brace up on your way home, or you go back to work. Well, the other thing that this particular group does is they'll follow up with you within 2 days of your incident. How's your ankle? Everything okay? Brace working all right? Got any issues? Everything good? This group is graded on interaction with their people as well as follow up, making sure that care's all there. They're averaging, once an employee calls on one instance, they'll call 2 more times before the year's out.
Ooh.
And why will they do that? I don't have to go to the doctor's office and take a half day off. I don't have to go to urgent care and get sick. I certainly don't have to go to the emergency room and get broke. And so back to my mom and kids of what do we do? Oh, Lord, what do? We have, our insurance is too expensive. They call TextCare. And then TextCare starts walking them through the system. And then if they need to see a doctor, TextCare refers them to a Garner doctor, high quality, low cost, best doctor. And so what we want to do is not replace primary care doctors. They're incredibly good people, have great thoughts, but they work for the hospital for the most part. They want all their diagnostic testing to be done in the hospital. They're owned by private equity or the hospital, and they're revenue generators, much to their chagrin, but that's what large corporations do. We need you to do this. This is our method of practice. And you talk to your primary care doctor friends that are older, they do not like the current system. So this is it's no cost to be used by the employee, no limit to how much you can use it. It's a flat $10 per head per month, and the ROI is 5 to 12%. We're trying to drive, that's one of the big pieces. That and Garner are the 2 big pieces that we're trying to educate people on using Airbo.
I remember because I met you, I came to your conference where you had the CEO of TextCare was there and Garner was there, and you did presentations on all of them and you chatted through all the data. And I was like, this is just such an innovative way of doing things. I loved it. Each company gets a doctor, correct? Or a nurse practitioner? Isn't that how it works?
Nurse practitioner, physician assistants. The other thing that's beautiful about this, that if you've seen any of these call centers, this is a group of people that work together. Now, they've got over 100 employees now, but they get up and they come to work and they work together. And because the majority, 80% of their interaction is via text. They can receive a text, look at it, look at the guy's record, spin around to their neighbor and go, hey, have you ever seen this? Does this seem weird to you? What do you think about this? And that's what they're doing. And they got the company dog walking through the middle of them and or got their feet up on the table. The physician's assistants and nurse practitioners love working there because of the professional interaction, the easy environment, and then the significant work that they're able to do to help people. people. And so the outcomes and the interactions are just unbelievable. They also have next to them a medical technologist whose job it is, you need to go see a Garner doctor. Do you want me to call their office and see if they can see you this week? They'll do that sort of thing. They'll call and do the scheduling of call in your drugs, call in your lab tests, call in your x-rays, your imaging. So it's a full service deal. And if they need to see something, you can do it with your camera. If they need to touch it, that's a problem. You need to go to your primary care physician to feel that carotid artery.
Yeah, but even I wouldn't want my PCP diagnosing that. I think it's interesting. It really touches on a conversation we had on podcast with Michael Stone. Yeah, he's in Portland, Oregon. We're in LA. So most of my interactions with him are either over Zoom or over text. And I have received better care from Mike and his group over text and Zoom that I ever get in person with a PCP. And we talked about that with Mike. I think we agreed to is that PCP has become almost like they're basically a data entry bot. A lot of what they're doing is interacting with a patient for as little amount of time as possible and entering it into a medical record and then triaging. It really can't continue this way. And we're very fortunate that we get to work with Mike. I love this service that you just highlighted, text care. I want my employees to have it. There's also some really interesting stuff coming out right now with one of my best friends is the CEO of a company called Keto Labs. And Keto just raised, I think, $60 million. They just announced their funding round this week. And literally, they're building an AI PCP. They're opening these clinics where someone walks in, they primarily interact with a human who can actually almost like a retail employee sort of human that really cares about the person you're talking to. They can have a one-on-one interaction. They take them through almost like a checklist of diagnostics that are going on. And then it's routed to a PCP or other specialist to approve a plan of care with a bunch of AI intervention along the way. And they're actively using this already. But I think that to me is probably the future of what we call the PCP, things like text care, things like that Kate and I are in, things like that Prashant is developing at Keto. The fact that most people still have to use a PCP, it's impossible to get good care in that system. It's just not possible. So I love that you're doing this, Rob. I think it's really important.
Thank you. Yeah, we do too. Thank you. And again, people are hurting. The system is not helping. It's not helping. And what terrifies me is private equity gets deeper and deeper into this. Not that private equity is the worst in the world, but they have a singular purpose, and that is to make more money. That's our future. I don't think it's going to get better. Getting people access to caring quality care at a rate that's affordable actually reduces cost. I see no downside for my clients, their members, or us in doing that.
I want to finish with two questions. I know we're kind of a little over time because you were very patient with us. Two questions are, first of all, what brings you joy every day, in your personal life, outside of fighting this demon that is the healthcare system?
Well, what brings me joy? What brings me joy is that I'm a child of God, and He loves me no matter what I do. Reflection on that and living there continues to deliver to me on a daily basis great peace, great joy, and good direction too.
That's beautiful.
Really is
That's
beautiful.
really beautiful.
Yeah.
As we round this out, last question is, folks walking away from this podcast, what is the one thing that you want them to remember from the last hour or so that we spent together? Maybe the one idea that you hope they take away and mull over in their own time.
There is a way to stop the escalation of costs and the reduction of benefits to your people. There are providers, methods that can reverse, unfortunately, probably temporarily, but ratchet down the costs and increase the benefits to help people. And if we just take a few minutes and you think about what you would talk about in your family if you didn't have insurance or couldn't afford to use it and needed care, that's why people buy the stuff, to give that peace, to give that comfort that, okay, I've got a loved one with a problem, I can get care. And so I would encourage people to hold their brokers, hold their advisors, do more, do better. Don't just bring me the rate increase. Show me what to do. Tell me what is good. Tell me how to do this. That's what I would encourage your listeners to keep pushing, keep looking, because this is a big problem that's hurting lots of people. There are ways to do this better.
I think that's a good message for all of us to keep in mind. Keep pushing. We can do better. You're showing a way for us to do better. We're so appreciative that, Rob, you found the time to join us today. To your point, who knows where we'll be in 5 years, but we can certainly keep pushing for the next 5 and see where this thing's land.
And I thank you guys for what you're doing to help us help our people understand this. And we need to do it better and more effectively. And Kate, we're in our 4th campaign. We're on slide number 6 of 8, so we're almost done. And then I'd
Yay!
like to get together with your team to critique it, and then we will roll those out quarterly going forward.
Perfect. I'm very excited to take a look at it once you're all ready.
Well, thank you guys.
Yeah, it's always I always walk away inspired after chatting with you. Really appreciate you, Rob.
Well, nice to meet you, Vlad, and you guys go have a beautiful California afternoon.
Yeah, we'll do. We'll do.
You as well in Chattanooga.